So, good morning, everybody. This is the latest one of our members' educational sessions. This one's about something several people have raised about what do we mean by various terms such as anonymized, pseudonymized, and anonymous, because they use more and more now, particularly when we're talking about how to use data and how to use it safely. So rather than it being it's very much an enabling technique to make sure data gets used appropriately. So what we'll do is we'll go through a few slides to go through these concepts, and I'll try and give some examples of where they're used, how they're used, why, and where it's useful, and some caveats as well. So the format will be the same. We'll go through some slides. We've got plenty of time at the end for some Q&A or chat or whatever people want to ask in terms of questions. I should also say right at the start, I've used some graphics from Understanding Patient Data. They are freely available on their website. They've done lots of work in the past to produce really interesting, useful graphics to explain lots of different aspects of patient data. And I've used some of theirs from an older report and some from a more recent report to go through in terms of the topics today around anonymization. If you've got any other topics that you want to cover, by the way, at any point, you can always email me on that email down there with any ideas for future ones, because all the suggestions come from you. So just let's start then. Right, lesson 101, why is health data collected? It splits into two purposes. The first one is obvious, to provide care to us as individuals. And the second one is to use it for other things outside of our direct care. And that's by and large where the split is. And those other things can be around research, it can be around planning for the NHS, a whole range of other type of activities, but it's not about our direct care. And when you look at the way data gets used, that splits into two largely as well. So to provide care for you, you'd expect that the health professional would be able to see your record, all the details about you, including your identification information, because they need to know who you are. Your doctor needs to know who you are, for instance, when he's at the bedside. The nurse needs to know. Similarly, other people outside of the direct clinical care team also need to know. So obviously the ones with the appointment staff. So if people are booking you an appointment, they'll first of all need to know who you are. They'll probably check your address just in case they need to set up ambulance transport for you. So there are lots of others who will see your identifying details outside your direct care, but it's all to do with that direct care responsibility. So I think that's relatively sensible and straightforward. The second part is around improving health care generally through research and through planning, as we mentioned. And for those users, by and large, the people who are doing that work do not need to see who you are and who we are. And that's why, simplistically, that's why we anonymize, why we de-identify data, to allow those people to do that, but protecting us, our identity as individuals. So a researcher would only need to know something about you rather than who you are. So for researchers looking at trends in bowel cancer instance, they would be looking for data on people who've had bowel cancer, but they don't want to know who those people are. They may want to know some characteristics about the person, but we'll come to that in a second. But that's largely where that simple split is between identifiable data use and anonymized data use. So what about anonymized or anonymization? So I've split this into two, anonymization and pseudonymization. They're both very similar. Both are processes which make the actual original data less identifiable by taking out things like names, addresses, and other things which could be used to identify us. The difference is that anonymization removes those identifiers and dumps them. Pseudonymization removes them, but in place of those identifiers, it creates a code, a pseudonym, a little cipher that you might hear about. And that allows potential re-identification. So it's a little key that you could use to go back to the original data. I've also mentioned down there that you may see some other phrases. There's a few there: personally identifiable, depersonalized, de-identified, non-identifiable. There are quite a few terms that are used with this, and it can get a bit confusing. So to start with that, this was a graphic from a few years ago now, which Understanding Patient Data, their logo's on the bottom, produced to try and give a very quick pictorial representation of identifiability as a spectrum. And they've used the phrase personally identifiable, depersonalized, and anonymous. And they was trying to get across the concept that if you look at the left-hand circle, that's clearly identifiable. You can see who that is. If you look at the middle circle, well, it's all a bit fuzzy. You can't really say exactly who it is. But for instance, if I knew that one of my friends stands exactly like that, and I bought her that blouse there, and she's always wearing it, and she stands with her hands there, and she's just got that sort of hairstyle, that's probably her. There's a degree of identifiability potential in there if you apply those principles. So because I would know those things, I could derive that it could be that person, but only from the other knowledge that I have. The box on the right is the depiction of anonymous. So this is where all identifiers have been removed, and that person is just a blob amongst other blobs, essentially a count of things in the anonymized data. So that's one graphic that was used. The more recent reports have gone into a bit more detail. They're beginning to use the phrase anonymized and pseudonymized, or anonymous and pseudonymous. So let's start from one of their graphics again, which I've taken from their most recent reports. Incidentally, I should say, if you want to look at the slides afterwards, or you want to look at the video, these are all click-throughs. So where you see the picture, if you click to it, it'll take you to the original report. You can go through that in detail. So the graphic they've used here starts off at the top. So identifying information plus medically relevant medical information equals confidential patient information. I think we've covered that on a previous session. So those two things combined equal confidential patient information. There's an example of those two things there, where the name, address, NHS number is identifying information about you. Other ones are about your medically relevant information. They've used them in blue, such as your medical problems, medications, and other things as well. If you want to anonymize things, the process of anonymization, as I said before, retains the things there in blue, takes off the identifiers in red, and throws them in the bin. So what the researcher would see is just a data set, a file, which includes those bits in blue. Pseudonymization, subtly different, in that it's generated a green, random, jumbled number. It's not an NHS number, it's just a ciphered number, a made-up number, a pseudonymization number, and it attaches that to the data that goes out to the researcher. And the people who are doing the pseudonymization, who hold the data in the first place, will retain that pseudonym against the name and address, the NHS number, and they keep that under lock and key. I'll explain why that can be useful in a couple of slides' time. But there is the fundamental difference. Pseudonymization generates a key which goes with the data to the researcher. The key means nothing to them, but it does mean something to the people who hold the original data in the first place. So on the topic of pseudonymized, let's start there first. The identifiers are removed, the unique reference number is generated, and it's therefore reversible. Now, because it's reversible, if you've got the key, pseudonymized data still qualifies as personal data under the GDPR, the General Data Protection Regulation. Pseudonymization is a really useful tool, though. So if a researcher is given the data set with a pseudonymized key, they don't know who the person is. But if, for instance, they spot something in the record which looks a bit odd, or they spot some real weird data quality issues that they think, actually, it'd be very important for the people who gave me the data in the first place to know about that, then they can send information back using the pseudonym, that pseudonymized number, to the people who hold the original data to say, here's a pseudonym, we found something odd in this record, you might want to check it in your original record. Then the original holders of the data can use the pseudonym, decrypt it, go back to the original record to see what's wrong in it. So there's a way back from the data that the researcher would be sent. And that can be quite useful in terms of things like data quality and other things. Just because you're given a pseudonymized number does not automatically give you the right to do that. There are a whole host of other conditions around processing of data as well. But that's fundamentally the difference. Pseudonymized data lets you go back under control conditions to the original full data. Anonymized data doesn't. The identifiers are removed. Because the identifiers are removed, it's not subject to GDPR in the same way. But there's a big but there in red. And this is from, I think, the Information Commissioner's Office's website. If any reasonably available means could be used to re-identify the individual, the data will merely have been pseudonymized. and therefore GDPR would apply. And this is where most of the difficulty comes in. So if you're going to give a anonymized record to somebody, but they hold other information, my first example that I know I bought a blouse like that for this person. I know the person stands like this. I know the color of their hair. Therefore, I'm probably able to re-identify that person. Then that could be considered to be pseudonymized rather than anonymized. There's a way back. There is an argument that says, is anything really anonymized in future as more and more data sets become available? So there's a but there, and explain the significance of that and what that means, the difficulty that generates in being able to give data out to people a bit. So even if you anonymize data, you've got to be careful that somebody else has couldn't be used to re-identify it, but you can also apply other privacy enhancing safeguards around that as well. I'll cover some of those in a minute. So as well as giving the data away, you can check that certain things exist, that certain conditions are in place, contracts, rules, regulations, secure environments, and other things. Several people have asked me, well, if data is anonymized, why don't you just put it on the web? And the problem is that if you put something on the web which is record level without the identifiers, then potentially my example, knowing that my friend has got that blouse with that hairstyle, with that stance, could re-identify. So you've got to be very careful about what you do make publicly available. Which takes us to anonymous data. This is easier in a way because if data is totally anonymized, if there is no way back, it becomes anonymous. That's the picture of the cloud, the stick people in the figures, the numbers. That generally, and GDPR does not apply in this case, so it's much easier to publish. In fact, government bodies who produce statistics are mandated to publish routinely available statistics. That's their job. So that's the domain they're in. They're routinely publishing anonymous data. Normally tables of numbers, tables of counts. You can release it openly. It can't be linked back to any person because it's just a number. It's just a jumble of stuff. And that gets routinely published. You'll have seen those all over the place on incidence rates are anonymous data, COVID numbers, anonymous data, waiting list numbers, very topical at the minute, are anonymous numbers. They're published. Now, that sounds easy and sensible, but of course that's open for anybody to use as they want. And that has caused problems in the past, which has caused people to question, well, do I really want my data to be part of anonymous data? Well, one example would be a few years ago, Public Health England, who are now part of NHS England, came under fire for supposedly giving cancer patient data about lung cancer to a tobacco firm. This was the headline that appeared in one of the technical literatures, but lots of broadsheets picked this up as well. And Public Health England came under fire because they had been linked back as the source of data. A tobacco company had engaged an organization to do some publicity for them. That organization had looked on what routine statistics are available, anonymous data, taken those, used something with it, made a story, and of course the source of the data was Public Health England. They came under fire for that. But fundamentally, it's one of those things you've got to accept. If you're publishing anonymous data, tables, rates, incidence rates, stats, counts, then there's always the possibility that someone will use them in a way that you didn't want them to use it. And this was a good example. And to their credit, Public Health England stood up and said, our job is to produce statistics that people can use. And other people may use it for means that we wouldn't particularly want them to do, but that's sort of the job, really. So it's just one example where not even publishing anonymous data can cause problems and embarrassment for those who are holding the data. Incidentally, I think in these situations as patients, our job is to understand that and begin to stand up for the people who are producing the statistics. Otherwise, they will get risk averse as well because they don't want bad publicity. So just one word on the boring stuff around standards. Some of us on the call, I know, love standards and rules. There are some really well laid out rules about how you anonymize data. It isn't straightforward. So there are sets of standards published by people like the Information Standards Board, by the Office for National Statistics. There are others as well. Those are just the first three I picked off. But there are some significant standards, clear standards about how you anonymize data and how you try to do it properly and how you ensure all appropriate safeguards have been taken. The one at the top is interesting, the Information Commissioner's Office. And again, these are all click-throughs, so you could read through at your leisure. But they published their anonymization standards, which recognized that even if you take identifiers off data, there's always a potential that somebody might have something that could be used to re-identify. So the Information Commissioner said, okay, as well as taking identifiers off the data, put these other safeguards in place. And the reason I mention that is if those safeguards in place, then another policy, which I think we've covered on a separate session around the national data opt-out, which is just England at the moment, I'm afraid. The national data opt-out does not apply when data is anonymised in line with what the Information Commissioner's Office have recommended. So even if it's record level data, because the Information Commissioner's Office have said, we're happy that if you do this, 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 and put these safeguards around it as well, then it can be seen as anonymised data, and therefore it can be released without having to apply opt-outs. Similarly, national data opt-out doesn't apply to anonymous data, although the data counts, for instance. But if somebody's producing those counts, they need to still adhere to the rules of data processing. So there are rules within that as well. The reason I mentioned the Information Commissioner's Office's Code of Practice and the data opt-out is if you look at the data releases, and this is from England because they're the most easily available in terms of publication, this rather daunting thing is a spreadsheet of around about 50 to 60,000 records, lines, each of which relates to a file of data which has been sent out from NHS Digital, as was NHS England now. So to the left-hand side, you'll see a file reference. That's just a reference of a data file that's been sent out. The thing I draw your attention to here are whether the patient opt-outs have been applied or not. So for each of those 50 to 60,000 data releases, you can tell whether the patient data opt-out has been applied. This the top two, in fact, the top lot say no on there. It also tells you what the data is that was released, where the data opt-out wasn't applied. But this is the particularly interesting bit here, the type of data. So because the data has been anonymized, which aligns with the Information Commissioner's Office's code, it's deemed as compliant to be anonymized enough to be able to send out without patient data opt-outs applied, because it doesn't identify the person. So there are lots of ways around the opt-outs that anonymization gives you that allows data to be used while still protecting the identity of the individual. The downside to that is if you were to look at the headlines, as some organizations have done, my simple count this morning of the latest one I downloaded from February, opt-outs are applied 9,700 times, opt-outs not applied 44,500 times. So there's a lot of data that goes out from NHS England where the opt-outs are not applied, but it's because they've been able to rely on the Information Commissioner's Office defining what is appropriate to how to anonymize data to make it so unlikely that anybody would be re-identified that you can still use the data. So it's a positive thing in that regard. The time it takes for people to do this, though, is huge. There's each data release needs to go through a whole set of processes to make sure it does comply before it can go out. And that increases the length of time it takes for a researcher to be able to get access to the data in the first place. So that's just one thing where different policies combine with each other. I mentioned other ways in which identification can be protected. And I've got a few examples. This is my simple example of data minimization. So here on the left, I've got a full data set, which I, as a data controller, can hold. This might be NHS Digital, it might be Scotland, it might be the Sale Organisation in Wales, but an organisation is legitimately holding these data, fully identifiable. Now, if I'm a researcher and I come along and say, I really want to look at the average length of life, but I want to do it by year of birth, it's not difficult stuff, then a minimized data set would be released to them. This is the process of data minimization. And again, this is what takes the time when the data controllers are giving data out to researchers. It has to be minimized. So all I would receive in that case was no identifier, just for instance, a data set with a year of birth and a length of life, which has been computed by the organization holding the data. So I don't even need to see date of death and date of birth. So I'd see 2 items. That's minimization. It's another way to anonymize and protect identifiability. Another example, if I want to look at time spent on a waiting list, you would do similar things. I don't need to know who the person is. I need to know the length on the waiting list. So that'll be computed from the date first seen versus the date on the waiting list. You can see what's going on. So the people who hold the data in the first place will create that length on waiting list field. That's what goes out to the researcher. And it's another way of protecting anonymity. It's part of the overall anonymity package. A last one, again, the same sort of thing. I want to look at the deaths soon after admission. In this case, it's looking at the days died after admission, which would be a number of account. That count can be done by the original data controllers. In this case, I've added on a pseudo number. And the reason I've done that is to say this could be useful if the researcher who uses that little data set finds some really odd ones. Or if you had hospital on there, for instance, they might find some really odd situations that didn't quite look right. And if they wanted to go back to the people who sent them the data in the first place, they could do that and say, we found something odd on these records, the pseudo numbers are this. And the data holders on the left-hand side know what that pseudo number is. They can go back to the original case and they can look at that record to see whether there's anything in terms of data quality or there is something that needs further investigation. So that's where pseudonymization is useful. It lets you go back, communicate back to the people who sent you the data in the first place under certain conditions. The other ways we can protect our anonymity, our identity is, instead of giving data out, that 50 to 60,000 lines on a spreadsheet where all data that's been sent out, you could say, no, we're going to keep the data and we'll bring people to the data. These things called secure processing environments, secure data environments, trusted research environments. This is held by the data controller, but instead of giving data out to the researcher, you set them a little space within the environment to say, okay, log in here and you can see these data items, you can see these bits. So no data goes out. It also means if they spot oddities, inconsistencies, queries within the data, they could just tell the people who are giving them access to the environment to say, would you like to check this? They don't need to resend any data out. It's a really good way of minimizing the data that gets seen, keeping it in one space, particularly supervising who's doing what with it, which might then let you be more permissive about giving more granular data out to people to let them do more work. The important thing with them is the only thing that ever leaves that environment are tables, tabular count, anonymous results. So that's just another way that's been developed now to, again, secure and protect our data, but particularly to make it more usable and hopefully, fingers crossed, to make it faster for researchers to be able to get into that domain and do their work and produce results faster and improve healthcare faster. And it would also hopefully let the data controllers be more permissive, let the researchers see that bit more that might be more useful because they can see all the time what the researcher is doing with that data. So it becomes safer for us as well. So that's another part of protecting identifiability, but making sure the data can be used in safe ways. The last one I was going to mention is this thing called synthetic data. This is certainly a way of protecting our identifiability because we're not in it. But the synthetic data is completely made up artificial data, but it's made up to look very much like real data. So it's got the same characteristics, the same pattern, the same structure, the same data structures. And when you analyze it, you get similar results. But the real purpose of this is to let people understand what the data looks like, to go around and try and work out complicated algorithms that could then be used on the real data. Now, they cannot do that at the moment. A researcher can't go and say, could you give me all the data because I want to try and see what I can find. Sometimes people call it a fishing trip, see what you can find. That can't happen. But with synthetic data, you could do that because it's not real. It's completely made up. You could go and generate whatever hypothesis you want, and then you could ask the people who hold the data to say, I don't need to know who people are. You're protecting identifiability. I want to just give you my algorithm for you to run against the real data. And it's another way of protecting our identifiability, making sure we've got anonymity, but opening up new ways of working with the data because we all want the data to be used. So that was my rapid half-hour run through of anonymity, pseudonymization, anonymization, anonymous, and other things. It is a spectrum. You can begin to take more and more out of a data set to try and make it less and less identifiable. The question is, how far do you go before you can stop it making it useful for the researcher. There are certainly techniques and security that we can place around the data to make it safer, therefore potentially to allow people more able to use it more readily in a more trustworthy, open and auditable environment. But we've also got to recognize that if people are getting access to data, then there's always a case that if they've got other things that they have in their possession, my point at the beginning, I know this person's got that blouse, I know that she stands like that, I know she's got the hairstyle, there's always a possibility that you may be able to re-identify. And that's just always going to be a risk, particularly in this day and age. So I think I'll stop there. Okay,